What's on the horizon in 2026 for our country's healthcare system? We're inviting back an accomplished national expert for his annual predictions about what he thinks will happen to healthcare policy in the next 12 months.
I think there's good maha and there's bad maha, right? So good maha is, eat right and exercise
100%.
more.
Yep.
And I think that there's a lot of wisdom to that perspective. And I do think, we primarily think of healthcare as sick care. And I think there's a recentering that's happening.
Our guest today is Dr. Sachin Jain. He's held top positions in the federal government and in the private sector, and he's an adjunct professor of medicine at the Stanford University School of Medicine.
There's a lot of positivity, well-earned positivity around the GLP-1s. And now we're hearing about oral GLP-1s that are going to be I think really significant for some of the major drug manufacturers that are going to make them easier, more accessible. As there's more competition, the price will go down. As the price goes down, more people will take these drugs. But, again, all you have to do is scan social media for, mentions of, Wegovy, Mounjaro, and you find countless people who are calling out, stomach pain or, rebound obesity or, some mental health issues. You just find, lots of different kind of potential safety signals.
And this is Conversations on Healthcare.
Dr. Jain, welcome back to Conversations on Healthcare.
Thank you so much. It's so great to be here. I was just thinking this is my third time with you all. So
absolutely.
Really appreciate the opportunity.
Well, we appreciate all
no
the
shortage of issues to talk about.
We really enjoyed your predictions last year and are glad to have you return. But we want to start out by asking you to tell us more about the secret sauce of how you develop your healthcare forecast and what factors do you consider?
Well, it's a combination of tarot card reading, palmistry, and crystal ball work. But actually, some of it is just, ear to the ground. I'm deeply invested in healthcare my whole career, have a lot of relationships, hear a lot of things. Some of it is wishful thinking, candidly. Some of it is things that I really want to see happen in the healthcare landscape. And, some of it is just based on, my own prior experience and instinct, a view of how things are going to play out. And I would say, out of 10 predictions, usually 7 over the last.
Margaret, he gets a lot right. So very impressed.
7 of 10. Two are kind of completely useless, and one is, a 50-50. So here I am.
Well, we're interested in all of them, and then we'll see how it pans out. But I thought it was really interesting that your top prediction for 2026 is that healthcare's artificial intelligence revolution will hit speed bumps. And you say this even as the U.S. healthcare sector reportedly leads nearly every other industry just in the rate of adoption of AI. So what leads you to that projection?
Well, I think that there's, kind of a hot air balloon that is carrying AI adoption. And I think we've kind of focused on some of the easy use cases like scribes and scribing. And I think there's the reality is that, the more complicated use cases are going to come when we start to really redesign process and we really start to redesign how the healthcare system works. And the truth is that AI every day of the week is going to run into a lot of legacy process that was not really designed for purpose. And we see this in our own organization at SCAN, and we see it across the startup landscape where some of the work that you see is being done by AI is being done with AI with some manual process in the background. And you're not going to hear that from many people because many people are invested in the outcome. The venture capitalists are really betting big on AI right now. But if you get them, and get them by themselves and you're having a quiet conversation with them, a lot of them will say that many of these companies are going to be commodified. Some of the big players are going to easily add functions and do so at zero marginal cost. So the ability to actually build a company in this space is going to be really challenged. And then, the reality is that we're still using a lot of computer systems that were built in the 60s and 70s. And so it's really hard to get the lifeblood that actually fuels AI, which is healthcare data, into a format where that data can be used to really improve care and improve processes. And I think we just dramatically underestimate the broken state of healthcare infrastructure and we'll need to build that infrastructure and rebuild that infrastructure before we're able to take advantage of the large language models and the new capabilities that are existing. That said, every day I drop my jaw and say, holy cow, I can't believe you can do that. So This is one where I really hope I'm wrong, candidly, because I am just super impressed by some of the things that are coming out from some of the big players and also from some of the small players.
You know, I always wondered if AI was going to do a little like cellular technology did to Eastern European countries, where we just leapfrogged over. We'll see if that happens here, sort of leapfrog over folks who don't have the legacy systems who are starting out fresh, but that's it.
Well, Mark, the thing I keep thinking about is, you know, I'm one of the folks who got really tired about all the healthcare analogies to Toyota that, you know, were pursued in the 90s and the early 2000s, and the Toyota production system and lean, and a lot of that stuff was really misapplied. But I actually think it's a really good analogy for what healthcare organizations have to do now. Most people don't know this, but Toyota was 8 times less productive than US car manufacturers before they built the Toyota production system. And, you know, if they just copied and pasted what Americans were doing, they were going to get the exact same results. But what they actually did was they redesigned the entire chassis for how cars were actually built. They went away from the assembly line to a completely different process. And I think that that's a bit of what you're going to see over the next couple of years. And you're going to start to see some Toyotas of healthcare in a way that we really haven't, even though we've been talking about it for 20 or 30 years. The other piece is that if you study the history of Toyota is you have to realize how long it actually took for that company to evolve and for the industries that it touched to evolve. They didn't actually start out in automobiles. They started out in the garment industry with hand looms. And it actually took 20 years for them to build these new hand looms that were far more productive than the original hand looms that they started with. And so, again, I think it's easy to think that this is going to happen like in a blink of an eye. But I also think the long arc of this is that we're going to have a totally different healthcare system in 15 to 20 years. I actually do believe that.
Well, thinking about different healthcare systems, the MAHA movement, the Make America Healthy Again movement, had a lot of wins last year. And you think they'll continue in 2026, and you believe it will go, quote, mainstream? What do you see happening?
Well, I think it's tapping into something that's very deep in the American psyche, which is a growing distrust of traditional healthcare, mostly because traditional healthcare isn't serving most people today. So most people don't have a primary care doctor. If they do have a primary care doctor, they're waiting 6 or 8 months. Most people really don't like take medicines. There's a deep distrust of the pharmaceutical industry, a deep distrust of pharmacy benefit managers. And here comes a politician and a movement that says, don't take drugs, change your lifestyle, focus on some radical common sense as they might kind of define it. And the interesting thing is it's just a message that's really resonating because I think most people feel really underserved by traditional medicine and also feel like the certainty that we used to ascribe to medicine really kind of blew up during COVID. Many people kind of realized that medicine is still a lot of art and not fully a science. And so that creates room for people to shift and change the narrative. And I think that's what's happening with MAHA right now as we speak.
Well, I think this is one of, in all seriousness, the most challenging areas for us all to grapple. So right now we have a really very low percentage of kids who've gotten the flu vaccine this year, and we're having this record flu season with all that comes with it, particularly hitting the adults, but also kids with fatalities. And a survey found that 83% of voters in the 35 most competitive U.S. House districts actually say the benefit of the MMR vaccine outweighs the risks, which would seem to be not such good news for MAHA in terms of where the country is heading. Do you think there's a chance that supporters of that agenda will be facing setbacks?
Well, I think there's good MAHA and there's bad MAHA, right? So good MAHA is, eat right and exercise more.
Yep.
And I think that there's a lot of wisdom to that perspective. And I do think, we primarily think of healthcare as sick care. And I think there's a recentering that's happening. So I think of that as being good MAHA.
Yeah.
Bad MAHA is when, we really kind of start to ignore evidence and start to make policy decisions based on feeling as opposed to facts. And, again, I don't want to comment on any specific policy, but what I will say is that you do see in local governments, state governments, examples of officials who are kind of writing their own script that are based on feelings instead of facts. And I think we have to start to recenter around evidence and really ask for more evidence in every single form, whether it's clinical trials, real world data, to really understand what's what, how things work, what's better, what's worse, and really drive policy. I think the other piece that's really challenging is that I think many people are rejecting coercion. They're rejecting coercion. And I think that that's at the heart of it. It's not even that they're rejecting facts. They're rejecting the mandates. They're rejecting the belief that, an outside party should be able to tell you what you put in your body. And I have my own opinions about this. I think, and there is a more communitarian view of it. We have to kind of think about everyone and not just ourselves as individuals. But I do think that some of what we're seeing is what Robert Putnam called out 30 years ago, which is the decline of social capital. People don't care about people don't care about social fabric anymore. They care about themselves because they don't believe that anyone else cares about them. And that's what we have to reverse more than anything. Is I think we have to really see this as a call to action to really rebuild the fabric of communities so that we see ourselves as being part of a greater whole. And being part of a greater whole comes with obligations to make sure that your elderly grandparents, don't run into people who are unvaccinated, who, unwittingly transmit the flu or other viruses to them. Again, that kind of sentiment has really shifted in really harmful ways. And what I'd like to see is our politicians on, both sides start to take on, a more global perspective that's more about unity, that's more about social fabric, that's more about connection, human connection. And I think we can do that, but it's going to take a little bit of time for us to correct our national discourse right now.
Well, I think in the Putnam's book, he also talks about the health of a community where there's high level of social capital. Two items that we always talk about in these interviews. You talked on
Mark,
the first one.
Can I say one? Can I maybe interrupt for 1 second? I heard a fact the other day that just blew my mind, which is, I work in the aging space, and I didn't realize the county level variation in life expectancy in our country. The highest life expectancy is in Breckenridge County, or the county in which Breckenridge is, in Colorado, and it's 90 plus years old. Right. And then our lowest expectancy is in a Florida county where there is a prison, and it's 64 years old. And when you think about that level of variation that exists, we're not one country. We're not one society. And, you have a whole county where people don't even age into Medicare. I mean, it's a little bit wild. And so, again, I think these are the facts that we have to talk about a little bit more, the healthcare disparities that exist, and really try to create, a common Manhattan Project around social connection and social health. Well, sorry to interrupt you. Yeah.
No, we appreciate it. We could go on many tangents, but we look at this and the potential years of life lost, which is another way of looking at what you're talking about with expectancy within each state, from one side of the state to the next, within people of different backgrounds within the state. And I think you've said it really beautifully about maybe replacing words like herd immunity with community values and caring for elders and protecting the most vulnerable among us.
Well, I wanted to shift to the second most talked about versus AI. You already asked that question. I want to talk a little bit about GLP-1 drugs. Right. You say the GLP-1 revolution will continue, but there will be some research news that really could give pause to the excitement. Wondering if you could share a little more about that.
You asked me how I come up with my predictions. Some of it is just having seen these things before. And while I haven't, we've never had a drug that is quite like the GLP-1s. I was at Merck when Januvia, which at the time was a real wonder drug for diabetics, actually started to see some safety signals where there was concern that Januvia use was linked to pancreatic cancer. Those were ultimately invalidated, but these safety signals do show up in real world data, and researchers will write papers saying, we saw a patient with. We saw a series of patients who have rheumatoid arthritis that's associated with, GLP-1 use. And all of a sudden, people will start to take pause. And I think, there's a lot of positivity, well-earned positivity around the GLP-1s. And now we're hearing about oral GLP-1s that are going to be, I think really significant for some of the major drug manufacturers that are going to make them easier, more accessible. As there's more competition, the price will go down. As the price goes down, more people will take these drugs. But, again, all you have to do is scan social media for, mentions of, Wegovy, Mounjaro, and you find countless people who are calling out, stomach pain or, rebound obesity or, some mental health issues. You just find, lots of different kind of potential safety signals, some of which will get amplified as these drugs become more and more material. And, some of those are going to lead people to question whether this class of drugs is as good as we think it is. It's just a natural part of any drug life cycle, especially a wonder drug like the GLP-1.
Well, you saw the stock take a bounce down after it didn't have the impact on Alzheimer's that they were hoping for. A rush study, but nonetheless impactful.
Yeah. Well, and the
part of what you do when you're at a drug company is you're always looking for more indications for your drug because you have a window of patent exclusivity. So you're rushing to find as many applications as you possibly can. And any signal is going to create, an even bigger market and a bigger market and a bigger market. And, with GLP-1s, frankly, I've seen nothing like it over the course of my career. People are talking about its use for addiction and alcoholism and, and obesity and a variety of other topics, so it's quite remarkable. And I think the end of this story has not yet been written. I think we're in the 5th inning of the 9-inning story.
Sure.
Yeah.
But the most exciting innings are, for any of us who watched the last, World Series, 6, 7, 8, 9 is when it really happens.
Right.
So.
And it's been a great science lesson for the American public who speak more conversantly on the issues now than I would ever have predicted people would in terms of where weight gain, obesity, and weight loss actually happen. Dr. Jain, we often discuss Medicare Advantage on our program and hear about the challenges that patients sometimes have with coverage, but you've predicted that you think Medicare Advantage is going to remain very popular despite its detractors or its haters. What gives you your confidence in Medicare Advantage really holding strong as the sort of the coverage of choice for seniors?
Here's the thing, is most people can't afford traditional Medicare with a supplemental benefit package. They just can't. And Medicare Advantage, there's been failures to update the traditional Medicare program to make it affordable for folks. And so, if you're a low or a middle income older adult in this country, Medicare Advantage is your only option. It really is. You kind of stack all the expenses associated with it. If you're a married couple going into retirement, you can decide to spend an extra $1,000 a month on, a traditional Medicare plus supplements, plus Part D, plus a Part B premium, or you could be on, an MA plan. And, you're not even going to use it most of the time because most people are aging into Medicare pretty healthy. So, I think it's going to remain very, very popular. Do I think that there's a lot of reform that's needed for the Medicare program? I absolutely do. I think, we should try to modernize the program, modernize, MA and fix MA. But I do think, by and large, if you're a low to middle income senior, MA is what you're going to choose. It's cost prohibitive to do the alternative.
Well, the advertisement market on that is so huge. I'm sure that's having a huge influence. This past year, Dr. Jain, we saw the Trump administration lead a retreat on health equity efforts, but you see it making a comeback, sort of a resurgence because you believe it's good business. But I'm wondering if leaders who support health equity risk running afoul of Washington.
Look, I led a discussion over the past weekend, and it was called, was health equity just a hustle? Because the reality is that you saw lots of organizations in 2020 coming out of the pandemic, actually at the start of the pandemic, plus, the murder of George Floyd, making big commitments to health equity, acknowledging major healthcare disparities in this country, acknowledging major challenges that, lower income Americans are facing. And so they made big commitments. And then as soon as the politics changed, they fired their health equity officers, they defunded their health equity programs. And it's almost like they said, just kidding. Now, the interesting thing about this is that, it shows the broken state of American healthcare leadership, which, for the most part, kind of goes where the wind blows. The interesting reason why I think that these issues are going to continue to resurface is because we have a cost crisis in American healthcare, and that cost crisis is disproportionately focused on people who have these major disparities. I mean, people who have a higher incidence of kidney disease, a higher incidence of ESRD, a higher incidence of cardiovascular disease, all cost the healthcare system more. So if you're going to focus on trying to lower total cost of care, deliver care more efficiently, you're going to have to focus on the populations where there is a cost burden and where there is a lot of challenge. And so I think, these topics are going to remain very salient, even if the words are changing. And personally, I don't think the words should change. I think the words are fine. They say what we mean to say. And we do need to really focus on populations where the traditional healthcare system doesn't necessarily produce the same outcomes that it does for everyone else, and make some adaptations. But unfortunately, I think health equity has gotten wrapped up in the DEI conversation, the DEI backlash, and the two things are actually quite different. Health equity is just saying, hey, there's a group of patients in this country for whom, the healthcare system produces suboptimal outcomes vis-a-vis the rest of the population. And that's a gap from a moral perspective that we should want to close. And, I think if we let that sentiment go away, then we should all go home. We should all just walk away from the healthcare industry. We should all just go do something else. Because in that way, we've really abandoned healthcare should be for the most frail and most vulnerable. If you're an ethical leader in healthcare, you should aim to take care of the people who really need you the most. And that's what we're really talking about when we talk about health equity.
Well, it's a midterm election year, as everybody knows, and that can spur legislative activity. I think you've indicated that you think it's doubtful Congress will tackle big healthcare bills this year, but that maybe Dr. Oz will lead the charge on introducing innovation. Tell us more about your thinking.
Look, you look at the history of healthcare reform, from FDR to Trump, and the reality is that lots of people talk about it, but very few people actually do it. I'd like to make a plug for, my friend David Blumenthal, who was my boss when I worked at the Office of the National Coordinator. He has a book that's coming out in a few months, and he recently relayed a conversation he had with President Obama about why he pursued health reform. And it was his mother's experience, difficult experience, accessing healthcare throughout her life, but particularly towards the end of her life, which really inspired him and motivated him to make a difference. And it really requires that level of conviction. Even when all of Obama's advisors told him not to pursue it, said it was political suicide, he did it anyway. And it's going to require that kind of conviction. And I think right now we have a politics of convenience as opposed to a politics of real ethical leadership. And I think, it's going to require that kind of ethical leader to push through that the malaise around these issues. And, it's totally possible that Dr. Oz is that person. I'm optimistic that he is. He's a really smart guy. He's very knowledgeable. He's taken the time to really understand CMS, its programs, and some of the big opportunities. But Dr. Oz has to work with a Congress, and Congress is not necessarily been functional in the way that I think many of us think of functionality. So I'm not necessarily sure that we're going to get the political momentum. Just remember, it was really a once in a lifetime event, for us to see through a set of very complicated circumstances after Ted Kennedy passed away for, the Affordable Care Act to get passed. So these things don't happen easily. I will say, there's more incremental healthcare reforms like the HITECH Act, which, wired the U.S. healthcare system by providing federal incentive payments to doctors and hospitals that I think will be very meaningful. And if you actually look at the $50 billion of funds that are allocated towards rural health, maybe this administration's massive contribution to U.S. healthcare has already happened. It's going to, if we can kind of see if those funds are used effectively and they're used well, maybe we can really strengthen the rural health infrastructure. I do think AI is going to help us enable, stronger rural health infrastructure. A lot of healthcare disparities are really driven by disparities in knowledge, disparities in access to knowledge. And I think it's one of the things I'm most excited about with AI is that, we are closing the gaps between, the most brilliant and most knowledgeable and, lay people by putting tools in their hands that actually ask them to get answers to questions when they're posed intelligently. So I'm pretty optimistic about that piece of
Well, thank you for reminding us, getting David Blumenthal back on the show. We've had him on before, but I want to talk about Congress. Have you made any predictions of around the midterm elections, or do you not stray out into that territory?
I don't stray into the politics. I like to stay more in policy. My crystal ball doesn't extend that far. That would be a good question for David, actually.
We'll ask him. Well, it is amazing how quickly time can fly, and we don't need AI to tell us that. A year ago, I think we were talking with you about Elon Musk and DOGE and anticipating a big drive for efficiency and budget cuts related to that efficiency. But I think the conclusion is they only reduced ultimately a fraction of what they aimed for, and largely it's out of the spotlight now. Do you think they accomplished anything? Was there an overreaction to their supposed impact? What's your sense?
I think that we do need a cultural revolution in healthcare that's about doing less with more. I think in healthcare, our kind of standard kind of stump speech, particularly when we go to Congress and we ask for, we speak to legislators, is we need more, because we want to do more with more. And the truth is that we know that we're reaching unsustainable levels of healthcare spending in this country. And so I do think DOGE's legacy may be that we're starting to ask the question, how do we do more with less in a more meaningful way? That's, the most optimistic take on it. The more pessimistic take on it was we made a lot of noise and we moved deck chairs around. And so, time will really tell. I do think that there are opportunities for us to improve efficiency and effectiveness of care delivery, but you have to know that most of that happens outside of Washington. It actually happens out in the world.
And so for those people where it happens out in the world, I'm wondering, just because our time is you've drawn up a set of 2026 healthcare leadership principles or resolutions. Maybe tell our audience a little bit about those.
Yeah, look, I think my fundamental belief is that healthcare has lost its ethical compass. I believe that we've been in a period of gross ethical erosion. Many of us started out in healthcare wanting to make a difference, wanting to leave things better than we found it. And, some 15, 20 years in this industry, many of us would say it's getting worse, not better. And I think the only way that's going to change is if we all start speaking much more plainly about how things are. And I do believe that one of the major challenges in healthcare is that there's forced toxic positivity. You go to most healthcare organizations, we're saving lives, we're doing God's work, we're changing the world. The reality is that we're also bankrupting people. Healthcare is the number one source of medical bankruptcy in the United States. Pause and think about that. We're literally bankrupting people when they're accessing healthcare. In moments where they need us most, we're extracting from them. When you think about the number of medical errors that are happening every day, the failure for people to be able to access care, we have in many cases normalized the abnormal. And so I think the work that we have to do as healthcare leaders, as moral leaders, as ethical leaders, is to start figuring out how do we actually name the problem so we can actually solve the problem. But there's so much pressure on us to not name the problem. Those of us who lead healthcare institutions, it's one of the reasons we launched a national advertising campaign. You mentioned, Medicare Advantage advertising. Scan's advertisement last year was health insurance is broken. Scan sees it. We're here to fix it. We're not saying we're perfect, actually. And that's very different. Normal Medicare Advantage ads have people, dancing on the beach, talking about their $50, Part B rebate. We're a very different kind of company, and we're trying to model that. But I think we need more real talk in healthcare. That's why I wrote those principles, is to give folks a framework and permission and a document that they can use in their organizations to say, maybe we do need to show up differently. Because the truth is that so much of the cynicism that exists among the healthcare workforce, the front lines of healthcare, and it's really well depicted on, the show The Pit, is a function of the gap between administrators and frontline workers. Folks who have this high-level macro view that doesn't take into account the frontline lived reality of the people who deliver the care and the people receiving the care. And the only way we can actually make things better is if we start to say, you know what, it stinks. Our organization stinks. We're not doing what we should be doing. And that's the first step to things getting better. And I'm very optimistic about 2026. I don't know what happened. I must have taken my vitamins or my Wheaties or whatever it is. But I woke up on 1/1/26 and I said, you know what, this is going to be a great year. And I wrote those resolutions with all the hope in the world that we can start to change the conversation in this industry. And I've seen it change. I've seen it starting to move in the right direction. And I feel like, you know, this movement that needs to happen is starting to build.
Well, I want to thank you for the clarity of your convictions and your insight, and for joining us again today on our show, Dr. Jain. And thank you to our audience for being here. And please remember to subscribe to our videos on YouTube, find us on Facebook and X, and please share your thoughts and your comments about this program. Take care and be well. This copyrighted program is produced by Conversations on Healthcare and cannot be reproduced or retransmitted in whole or in part without the express written consent from Community Health Center, Inc. The views expressed by guests are their own, and they do not necessarily reflect the opinion of Conversations on Healthcare or its affiliated entities.